Before we address the topic for the day on bronchogenic carcinoma, let me just address these two questions. First being, where are we in the fight against cancer? And what is the current outlook for an individual diagnosed with cancer? Now, for the first question, we are definitely at a better position compared to where we were about 25 years back. However, the outlook for an individual diagnosed with cancer is variable. For instance, patients diagnosed with hematological malignancies like lymphomas and leukemias are at a better position of survival compared to those with solid tumors. Solid tumors, people who are diagnosed at an early stage have a curative outlook, but unfortunately most individuals with solid tumors are diagnosed at an intermediate or at an advanced stage, making the outlook no better than what was there before about 10 or 20 years. So the learning objectives would be to understand the etiology and the clinical presentation of bronchogenic carcinoma, to understand the tools currently available to diagnose them, and an overview on the treatment of the disorder. Now, what causes bronchogenic carcinoma? So this slide will clearly explain you that if you divide the etiology into 3 compartments, each being 1/3, smoking contributes to 2/3 of bronchogenic carcinoma. So remaining is contributed by exposure to silica, asbestos and radon, and a reasonable proportion present without any clear risk factors, especially in women. So what are the presenting symptoms of bronchogenic carcinoma? So before going into that, let us look at the behavior of bronchogenic carcinoma. Now you can see that if you look at the number 1, which corresponds to the hilar node, hilar location. It can manifest as a mass in the hilar location, or it could present as a clear parenchymal mass in the lung field, the number 2 in the diagram, or it can present like a parenchymal mass but blended with the margins of the lung, as you can see in 3. Commonly as pleural effusion, peripherally located bronchogenic carcinoma extending into the pleural space, which is represented by number 4. 5 again by a mediastinal mass-like presentation. 6 as a presentation after involvement of the pericardium in the form of pericardial effusion. 7 as a collapse of the lung or elevation of the hemidiaphragm due to phrenic nerve palsy. And the collapse of the lung can occur due to occlusion of the bronchus leading on to the collapse of the lower lobe, or it can manifest as invasion of the rib. So this is all local, how it can spread and how it can manifest. Apart from this, it can take a lymphatic spread through which it can spread to all the lymphatic organs in the body. It can go through blood also and metastasis, and it can be paraneoplastic. So now we can guess the symptoms as when the part of the parenchyma or the pleura is affected. So it presents as cough, which is usually a dry cough. For a smoker, the character of the cough will change. The usual smoker's cough changes its character indicating that a mass lesion is developing inside. Or when the mass lesion cavitates, it can manifest as hemoptysis. But when the extent of the mass lesion widens, a larger area of the lung gets affected and they can present as breathlessness. And it can also present as a change in the voice when the nerves supplying the vocal cord is affected, or when it's directly extend to the larger airway. It can manifest as difficulty in swallowing when esophagus gets infiltrated, or the symptoms can be a consequence of distant spread to the brain or to the liver or to the bones. So the challenging part is when it manifests as what is called extrapulmonary manifestation. Here what actually happens is an endocrine kind of a manifestation in the form of decreased sodium, hyponatremia, which occurs in syndrome of inappropriate antidiuretic hormone, or it can mimic a Cushing-like syndrome when it is due to an ectopic adenocorticotropic hormone, or when there is excessive secretion of the parathormone-like peptide. It can manifest as hypercalcemia, manifesting as renal failure or hypercalcinosis. And neurologically, it can manifest like a peripheral neuropathy or a myelopathy as a consequence of infiltration affecting the vertebra, and which in turn compresses the spinal cord. Occasionally, it can also manifest as ataxia, instability in gait, as a consequence of degeneration of the cerebellum, or the neuromuscular junction getting affected, and they present as myasthenia-like syndrome. Now, what are the clinical signs of bronchogenic carcinoma? Again, this can be divided as lung signs or extrapulmonary signs. Lung signs can take the feature of a pleural effusion or a lung cavity, or when the lung mass is very much expanded, it can cause supraclavicular hollowness or infraclavicular hollowness, or fullness in one part of the lung where the lung mass is actually expanding, or when it actually invades the bone, it can manifest as a bone pain. It can invade the venous system, wherein it can present as a superior vena cava syndrome, or it can invade the sympathetic chain and present as features of Horner's syndrome. Now, most of the times when symptoms are suggestive, or when you decide to take an X-ray, which is for some other reason, but it looks very suspicious, you need to take a call on how to go about beyond the suspicious X-ray. So this is a typical example of an X-ray which is showing a clear mass in the right upper zone. You can see that the right upper zone, there is a homogeneous mass occupying a large part of the right upper zone and little bit of a middle zone also. You can see that the trachea is deviated to the left slightly, showing a compressive effect. On the other hand, when the opacity is quite small, as in this case in the left side, you can see a small pulmonary nodule, which is a potentially early stage of bronchogenic carcinoma. How to go about in the evaluation? An ideal starting point will be induced sputum to look at sputum cytology for malignant cells. You can see that even in early stage, sputum cytology for malignant cell is a good tool. Alternatively, you can ask for a bronchoscopy, which will look into the possible endobronchial spread, or external compression of the bronchus by a medially placed tumour of the lung. Now these are the common radiological presentation you can get. You can have a unilateral hilar enlargement which could be due to a central tumour, or it can be due to a hilar lymphadenopathy. Second one will be a pulmonary opacity, which can be a mass lesion as I showed, which may or may not have a cavitation. When the lung mass is affecting the bronchus internally or externally, it can lead on to occlusion and a collapse of the lung. It can manifest as pleural effusion, a very common imaging finding which we see clinically. Or it can be a broadening of the mediastinum as a result of a paratracheal lymphadenopathy or a malignant pericardial effusion. Now when the rib gets affected, it can present as a destruction of the rib also. So the spectrum is quite broad, which can give you clues that the patient is probably having a bronchogenic carcinoma. Now what are the pathological types? Now adenocarcinoma is the most common thing, which manifests as either a pleural effusion or an internal mass lesion, and it contributes to about 35 to 40% of the cases. Followed closely by squamous cell carcinoma, small cell and large cell carcinoma contribute approximately 50% of the pathological types. Now this is a situation where X-ray didn't show much, but a CT, the yellow arrow, shows you that there is a periphery located. It looks just like a pleural thickening, but it is not uniform, giving a suspicion that whether it could be a atypical imaging finding of a lung cancer. Now when you go ahead and did a PET scan, you can see that the signal intensity indicating that it is a metabolically active mass which could indicate a bronchogenic carcinoma. So imaging plays a very critical role when the suspicion is not that strong, but it may lead on to identification of the tumors at a very early stage. Now how to treat? Is bronchogenic carcinoma curable? Well, it is curable only at a very early stage where the tumor size does not exceed say 3 cm. We call it as stage 1, when there is no involvement of any node. Now when the size slightly increases, you call it as 1B, where it goes up to about 4 cm. Again, the chance of a curative surgery is quite high. But beyond that, like when you go for a higher size of the tumor to A, to B, when there may be the just increase in the size with or without involvement of the ipsilateral hilar node, the possibility of a resective or a curative surgery is relatively less. Now it becomes worse when it goes to 3A and 3B and 3C, and when there is a metastasis, the possibility of a curative therapy becomes very much less. So there are a few contraindications where we cannot go ahead with the surgery because outcomes is not going to be as expected. One is straight away when there is a distal metastasis, or when there is a malignant pleural effusion, when the node has moved to the opposite contralateral side causing enlargement of the mediastinal nodes, when there is invasion of the structures like the heart or the trachea or the esophagus, when the lung capacity is quite bad, or when the patient has other conditions of the heart or other medical conditions which may make the outcome of surgery poor. So unfortunately, 75% of those diagnosed with lung cancer have at least one of these contraindications for surgery. Now as I told you, surgery is for stage 1. The survival rate is reasonably good at 75% at 5 years. Chemotherapy options will include with a combination regimens using cyclophosphamide, doxorubicin, vincristine or cisplatin and etoposide. This is for small cell carcinoma. Non-small cell carcinoma are not usually that responsive to chemotherapy. However, platinum-based therapy is used. And along with chemotherapy, radiotherapy is also utilized, especially to bring down the invasiveness of the tumor over the neighboring structures. Well, there is a role in certain group of people who have mutations of the epidermal growth factor receptor gene. And they can be treated with tyrosine kinase inhibitors like gefitinib and erlotinib and other monoclonal antibodies like bevacizumab. However, the outcome is not that great when the stage has reached the intermediate or advanced stage. So, the prognosis is fairly bad. 70% die within a year and only 8% are alive at 5 years. Early diagnosis is the key, but the issue is we are not able to have an early diagnosis